good. Okay, so we've got a 4-year-old French Bulldog with a grade 3 medial patellar luxation. This is David, this is Sandy, Adam today, so we're going to do the correct test. The plan will be worth the light and awesome. So the plan will be to do the block sulcoplasty and the distal crest transposition. Hopefully we do not have to do the distal femoral osteotomy. The distal femoral angle is at the region of the borderline. So we'll see how things go. It might be potentially an option for this patient if two methods earlier do not do the trick. So we start to see the patellar tendon. So the patella is here, so let's just see if we can rotate it.
This one is
So this is it. Okay.
lower
there we
limit
go.
manus.
Is it that one where you press that on the
Yeah, he's just
So
taking
we're
it.
going to just go on the side of the joint. We'll do parapatellar arthrotomy. There's a joint fluid here. There's quite a bit of joint fluid. Let's see if we can rotate it. Now, the next step will be to inspect the joint space, just to make sure we do not have any concurrent problems. And this in fact will be potentially a cruciate ligament damage, so let's have a look. Get some small doggies. So the cruciate ligament seems to be okay. See, inside. Okay, so we don't have to do much about the cruciate ligaments. tear, but that's nothing that would concern me. So let's just now open this a bit more. Okay, I'm just holding it that, perfect. So here we've got a bit of damage to the ultra clear ridge. And this is where it was luxating. Also we've got some cartilage damage here. Some osteophytes. Yeah, we're going to make it a bit deeper. Not much, but still. I'm going to come down with this one. This should be hopefully deep enough. So next step, we're going to make a block, so that should be wide enough. What I want you to do is just to hold it with your finger here, so it doesn't have to jump off. Okay, come. Let's see. That's our block. Sometimes you can break the block when you're doing it, so it's always best to be extra cautious. And at the end you can either preserve the distal attachment or take it off. I personally would prefer to take it off and put this in a saline solution. So keep it. Now next step is we're going to make it deeper. So let's just go a bit deeper here. Same here. And then I will aim for maybe 1 to 2 millimeters. Sometimes I tend to help myself with oscillating saw, but on this occasion we will do it without it. So, fragment by fragment, step by step, we're getting there. Now, if we were to see where's the proximal bit of the femur, so here we still have got a bit of step to go for. So, let's just take this out. What might be helpful here is just to make sure that we've got depth. Good enough. Looks fine. Looks fine. So let's see if the fragment will fit now. Sometimes we have to make it a bit wider to make it fit, but let's see how things go on this time. I think that we are going to make the bed for it a little bit wider on the sides. Just a tiny bit, not much. And to do that, I'm going to use those silicone soles. Try again. And we'll try this upside down maybe. And upside down it looks like we've got a good depth here. How deep can we go with that? I'll be tempted just to do that. So now let's put this back in. So it's got a really good deep base now. Okay, so now let's take this out. And we're going to go for the table press transposition. So let's put the kneecap back in. It's a good practice to see what the kneecap looks like underneath. So we'll grasp it, flip it upside down, and as you can see, it's quite worn over here. So the kneecap has been luxated for a long time, so this is the cartilage damage. This back in. So how much to actually do the transposition of? Now this is internally rotated, so I think we will be aiming for just to move the tibial crest around here. So that should be about 1 centimeter. Flush as we go. So usually the place where we cut should be 1/3 of the proximal tibia. So this one we've got 1, 2, so it should be cut just right here. And it's always worth to take the patellar tendon. This with the patellar tendon, if you damage it, then it's a catastrophic complication. So let's try to put the gouty. Maybe let's take this one out for a sec. Let's keep that instead. Perfect. And we're going to go for the cut now. So it's useful to put this under 90 degrees. And then we'll start cutting now. It's useful to preserve the distal periosteal attachment. Let's see how far did we go with the cut. So here we've got basically already a good level of cut. We're going to detach this bit and we can take this one out. So once we are at this phase, we can do the tibial crest transposition. So it still is basically attached to the distal portion. And we're going to move it laterally. It's here. So it's 1.4. So let's move the tibial crest laterally. Maybe we would have to move it quite a bit. So the first pin is preventing it from moving medial. And we are going to use the pointed reduction forceps now to compress it. Probably will be useful to compress it a little bit more. Let's see. So let's see if that's enough. I mean, once we do the soft tissue, then it doesn't want to luxate anymore. So this is good. I think I would like to just try to compress the fragment a little bit more. So I'm going to try to go just behind it here. Would you mind flushing this? So that's good. We'll just place one more pointed reduction forceps here, just below. Okay, that's fine. And the next bit is just to put two 1.4 pins through the tibial tuberosity to stabilize the fragment in a new position. So if this is the patellar tendon, I'll try to go a bit above. Actually, no, sorry. This is just a thing. Would you mind just trying to retract this somehow? So this seems like it did go through both cortices, which is good. We're going to put one more pin and then tension band wire in a bigger effect. Now towards 1.4 and where did I put the rest of the pins? Yeah, perfect. So we are going to put this one probably just a bit below. Now this seems like both of them, they are actually through. That's good. So what do we do next? I think that it will be worth to put the tension band wire figure of 8. And we are going to do that in the distance, which is equal to the length of the osteotomy. So let's just expose some of the bone distally. So if the osteotomy ends up just right here, we should make a hole somewhere in this particular region here. So I don't want to make a big approach. I want to keep it relatively small, so we should be fine with this size. So I will ask you, David, would you mind to hold it like this? Perfect, thank you. Now I'll handle it. Okay, so that's good. And we are going to take the size of the wire. I think this will be probably fine. So let's go with the size. Okay. Alright, carry on. So now we will need to find it from the other side to make this easier. Okay, I think I can feel that pin. Not the pin, the wire. So we put the wire. So we are going to do the figure of 8 now. I think we don't need that one anymore as much. So we'll try to go just under the point of deduction forceps. Go around this pin. See if I can go just close to them as long as possible. This one also will need to go through that hole. And we're going to twist it. To make it easier to twist, it's useful to trim the wire. And then the rule is pull and twist. Okay, this is enough. Let's cut this short. And bend it against the bone. That's fine. This pin is not necessary, we can take this one out. There was the difference. those have to be bent. So they don't cause any trouble to the soft tissues. See if you can just press a little bit more against the bone. That's fine. And now let's hold this one. And this one. Okay. This is it. Flush, please. That's good. So let's see. So the compression is okay. Now let's see just again if I can. So let's just flush the inside of the joint. Would you mind, please? So it doesn't want to luxate as much anymore. So we're going to close the soft tissues now and take it from there. Can I have a PDS video?
Fourth shelf, I think I do. The fourth shelf down.
Boss man.
Yes. I'm looking. I put two spines on top of this one, so if somebody takes my appointment, then maybe, but I think maybe tomorrow, yeah. So let's stick with that. Alright, can we inside?
Yeah. Good, thank you.
Right, okay. So let's just maybe rotate it like that way, please. So to stitch up the joint capsule, there is a modified Mayo pattern which we tend to use. It can also be called vest over pants. I tend to use PDS 2.0 for this purpose. That is basically capsular indication and reduces the risk of the relaxation even more. It's just essentially closing the joint capsule in a secure way. Very similar principle when you're closing the chest after an intercostal thoracotomy. So I think we're going to put around 3 stitches here. That's 2. And just 1 more. Right, so let's make sure we've got a good reposition of the patella. That seems to be fine, sorry. And we are going to close the joint capsule now. Perfect. Let's go with a second. And the last one. again, last flush. We're going to check the femoral patellar tracking now to see if that's going to be enough. So femoral patellar tracking is okay, there is no rubbing. The kneecap doesn't want to luxate anymore, even if I push it, so I think that's gonna work. So we'll see. Now let's just close the subcut and everything else. How's this so far? She all good, Sandy?
Pardon?
She's all good?
Yeah. What's that, 35 minutes?
That will be a short video then. So now the Aberdeen knot. We'll continue with the next layer. Somebody's waiting for his turn.
That's the bitch thing, maybe waking up.
Do you think?
Sounds like a Labrador.
We can pre-med the next one, by the way. So just see if you can put on a group, please.
See if anybody's available.
That we can pre-med the first spinal.
So as in Arthur, isn't it, like that?
Mm-hmm. Skin stitches or intradermals? Intradermals. This one. So in terms of relaxation, if we ever get the relaxation here, then the next step will be the distal femoral osteotomy. I will have to cut the wedge of the distal femur and do a plating job. We can plate it on one side or both, so we can do either a lateral plating or a double plating, so then we would have to approach also the medial aspect. I don't think it's necessary for this particular patient. I think we should be just about fine with what we did. With the spine, are we doing it here or in the number 3 instead? No idea.
Pardon?
Where are we doing the spine here? In the...
In here, hopefully.
Okay, that's fine. Can I have some skin glue, please? Okay, that's it. Alright, so we'll do some glue now. Take all this off.
You got a needle for that? Puncture that.
That should be fine. We're just going to puncture it with the needle. We got an even new ones. Just for the next.
Yeah.
Okay, this is it. So that's the last check. There's a good femoropatellar tracking, no relaxation. Feels good. Thanks for watching. Thank you.